So welcome everyone to our JACC Case Reports Roundtable. I am happy to moderate this session with my co-moderator, Dr. David Fischman from Thomas Jefferson University. I was the chair of the chest pain guidelines, and I'm honored today to be with some of my co-authors and case presenters. So I'd like to introduce Dr. Wael A from Cleveland Clinic, Dr. Leslie Shaw from the ICANN School of Medicine, Dr. Phillip Levy from Wayne State University, Dr. Debabrata Mukherjee from Texas Tech in El Paso, and we have two presenters today. Rakhee and Tiffany will be presenting our cases and work with the respective faculty here. So we're going to start with case one. And this first case will be presented by Rakhee. If you want to go ahead and pull up your slides.
Thank you, Dr. Gulati. This is Rakhee Makhija, one of the fellows here in Texas Tech University, El Paso, with Dr. Mukherjee. We have a 45-year-old gentleman who presents to the emergency department with for chest pain. He reported having chest discomfort for one time 5 days prior, which lasted for a few minutes after an altercation with his co-worker. At that point, he didn't seek any medical attention because the chest discomfort subsided pretty quickly. He then had the recurrence today about an hour ago, our prior to presentation to the ED, after having another altercation with his same coworker. But this time around, the pain lasted longer. And he describes his chest pain to be substernal, dull aching, non-radiating, associated with shortness of breath, about 8/10 in intensity, lasting about 10 minutes. And this was relieved on his way to the ED. Of note, he does have active tobacco use. He does not take any medications at this point for any other medical problems. His family history is notable for coronary artery disease in his mom at the age of 69 and hypertension in his father and grandfather. During his last physical with his primary care physician, he had noted to have a normal blood pressure, A1C of 5.3, a lipid panel within normal limits. He's active, he exercises daily for about 30-40 minutes and notes no significant limitations with exercise. In the emergency room, his blood pressure is noted to be elevated at 157/86 millimeters of mercury, heart rate at 895 beats per minute, oxygen sats at 98%, and a BMI of 31. On examination, he's a well-nourished gentleman with normal JVP, normal carotid pulse, heart rate and rhythm were normal. S4 was appreciated without any murmurs. Abdomen soft, non-tender, no pedal edema. A 12-lead EKG was unremarkable, normal sinus rhythm without ischemic changes. Currently chest pain free. On the blood results, the high sensitivity troponin at the institute was 1 picogram per ml. And an hour later, it was 1.1 picogram per ml. And just to highlight that the normal is less than or equal to 12 for men in our institution for this assay. So we note that the change in his high sensitivity troponin level is less than 6 at 1 hour. His heart score is 2, his EDAC score is 8, his MDAP score is 0. He does represent a low risk category for having an ACS event, and the 30-day risk of death or major adverse cardiac events is less than 1%. Based on this data, it's highly unlikely that this is an episode of ACS. Therefore, the patient does not require any further testing and can be discharged safely with an early outpatient follow-up. One exception is if the two troponin values, the initial troponin level, if it is very low, a single measurement may be sufficient if the chest pain began 3 hours prior. Also, we want to highlight that the numbers are assay specific. For the particular assay and for the particular institution, the change in 1 hour more than 6 is significant, and clinicians should be aware of the cutoffs at their institution. That is the end of the case, and some of the questions pertinent to this case is, what is appropriate or early follow-up? I would like to call upon my mentor, Dr. Mukherjee, at this point.
Thank you, Rakhee, for that elegant presentation. I think the questions will be handled by Martha and David. So, but thank you, Rakhee. That was very nice. You want to take over, Martha?
Yeah,
Or
I
David?
think this case highlights probably frequent occurrence into the emergency room, urgent care settings, and I think, as you mentioned in this, early follow-up. And one of the questions I think is, for the low risk patient, what is appropriate in early follow-up with, at what time frame, and with whom? And I'll ask Deb if you could answer that question.
Yeah, thank you, David. Happy to tackle that. And I think one of the key messages, and I think key contribution of this guideline, is that low-risk patients do not need inpatient or urgent testing. And if you look at the data for low-risk subset of ED patients with chest pain, there's no evidence that stress testing or cardiac imaging within 30 days of the index ED visit improves their outcomes. And this is a big change. The prior guidelines for non-STACs and other guidelines had recommended a stress test within 72 hours for patients with acute chest pain, which meant, logistically a lot of work in arranging this test. I do want to emphasize that many of these patients have baseline cardiac risk factors that need to be managed. So there needs to be pathways to facilitate outpatient follow-up for further evaluation and guideline-directed management of cardiac risk factors for these individuals. So we don't want them to fall through the cracks. The guidelines do not specifically define a time frame and with whom, whether PCP or cardiologist, but I think it's very reasonable, given that the risk is very low within the first 30 days, to arrange a follow-up within 4 weeks. And it can be with a PCP or a cardiologist, somebody who can meaningfully evaluate them. Now, some hospitals, some emergency rooms try to get a visit earlier. That's to try to keep them from coming back to the ED. But I think certainly within 4 weeks, and either a PCP or cardiologist who can assess risk factors, some of these individuals may benefit from an exercise ECG or a calcium score and can make a determination, but certainly nothing urgent or nothing in the hospital.
Do you think it's incumbent upon the emergency rooms to make sure there's a set time frame, contact the primary, that there is a follow-up? Because as you said, I'm afraid of getting lost through the cracks here.
I think there should be a mechanism, whether it's a navigator in the ED or a nurse assigned, that needs to be a mechanism where there is follow-up with these individuals and they get either an appointment is made or they are told who to call. If they do not have a PCP or a cardiologist, give them some numbers. And, very efficient hospitals may be able to make that appointment before they leave. But I think it's important to have a mechanism, whether it's the ED nurse or a ED secretary or somebody that makes that arrangement. So we don't want these patients falling through the cracks and several months later come back with an event.
Rakhee, can you please close your slides? Thank you.
Martha, can I ask, are we allowed to comment on those comments, or do you want only answers to the questions? I wasn't sure.
I think you can, especially as an ED physician, we'd be very interested in your take from that as well. So if you don't mind chiming in, of course, go ahead.
Yeah. So if it's okay to add to that question, David, from the emergency department perspective, the things that Deb keyed on are real. It's hard for us to get people into outpatient appointments, but what's also really hard and underappreciated is that we just told somebody that their condition that they feared was life-threatening is now nothing. And then I'm going to say, but you got to follow up. And so how to do that in a way that doesn't discount the value of the negative information, but still tells them that they're at risk for something like future complications, which may be a year, 2 or 5 years down the road if they're related to diabetes or hypertension, is really important. It's a nuanced thing. When we've tried to do this from our ER, even giving people an appointment made within 48 hours, only about half of them show up. So it's kind of interesting to think of that side of it, the patient-centric side of it. And I think to Deb's point, having an individual who has the responsibility to reach that person and help explain the value of risk factor mitigation as opposed to just treatment of symptoms and complications down the road is really important.
And I think also patients want to know what caused my chest pain as well. So it's always hard if you don't have an answer. I think one thing in the chest pain guidelines that it has helped is if we start using that shared decision-making tool that Eric Hess had developed, I think that would help us, because we saw that patients understood why they don't need further testing, and they were better able to appreciate themselves that they didn't want the additional testing either. So I think if we use those tools, it would be great. So Phil, since we have you here, you noticed in the case that there was multiple risk scores that they'd use clinical decision pathways. Does one work better than the other, and how do you choose?
The one that works best is the ones that people like to use, right? So that's the most important thing. And for whatever reason, people have their favorites, right? And some institutions are heart score institutions. Some still want to use TIMI, even though it's probably not as good as some of the more recent ones. You go to New Zealand, you're going to get an EDAC score because Martin Than has made it that way, right? So I think the bottom line is that when we wrote the guidelines, we appreciated the diversity that exists in risk scores, and didn't say anybody needs to use any single risk score. We said you got to pick a risk score, actually a clinical decision pathway, right? Taking a risk score or taking a biomarker-based pathway like the European Society of Cardiology 0 and 1 hour evaluation, and basically said, let's just get something that everyone's going to agree upon in an institution, so that one patient, is an MI according to physician A and not an MI according to physician B. You can't have that heterogeneity within institutions. And ideally, you shouldn't have them across institutions in the same region that are potentially using the same assay, right? You can't have an MI be diagnosed at one facility and not another. So I think these types of conversations and multidisciplinary meetings to determine what everyone's comfortable with and what level of risk people are willing to accept before sending someone home is really important. The one thing, as I think we all know, that we really hammered home in this is that low risk is less than 1% chance of having 30-day MACE events. And really, as we showed nicely, I think, in our summary tables, any one of these risk approaches, these clinical decision pathways, can get you to that low risk designation. You just got to pick one and stick with it.
In cardiology, we have a lot of risk scores. The real question is, how often are they being used?
Yeah.
And I guess any sense in the ER, the frequency in which they're actually being used?
They're being used actually a lot. Whether they're being documented is a whole nother ball of wax, right? I mean, if they're NCDR participating centers, you bet they're documenting because it's part of the chest pain MI registry. But that aside, documenting, I'll start with that second part first. Documenting is important because it gives everyone the objective information as to what you were thinking and to what they may want to be thinking when they see this patient subsequently. But I'll say that a lot of ERs have moved towards using these risk scores and clinical decision pathways because it helps get people out the door. And that really is a lot of the name of the game, especially now with COVID, right? We can't be keeping people in the ER who need a stress test within 24 hours only to get that stress test done 5 days later when the bed finally opens up or the opportunity to get into the stress lab becomes available. So I think that comfort that comes with these clinical decision pathways makes them much more likely to be used. And I know in the ER community, we talk about this all the time, and emergency department leadership, across the country have really pushed this approach.
Right. So Leslie, I'm going to call upon your expertise, and Phil, you can weigh in, and it's a little different. What about the intermediate risk patient in the ER? How do you decide doing a CAT scan, a CTA versus a stress test? How do you make that decision?
Well, I think that the case that was presented does give us a little insight into kind of what the questions you would ask yourself. For example, this patient, if they were a little bit higher risk and an intermediate risk, you would still be kind of leaning towards that idea of maybe the information I want is, am I trying to exclude coronary disease? Or do I think their coronary disease is milder? In that case, you might lend yourself to thinking about an anatomic test like CTA. And if you are thinking that this was the history was really exertional. I know this was stress related, but there were other factors that put this together, this package of a lower risk patient. If you had some idea that the patient had exertional symptoms and you're worried about the provocative ischemia, and you thought that their likelihood, I mean, this is a 45-year-old man, if you thought their likelihood of obstructive disease was higher, then you would really go down that thought of ischemic management, and maybe a stress test would be aligned. Of course, you have to know what your expertise is at your institution. If you're always doing CT, then CT is something that you're going to feel very comfortable with. If you're usually doing stress testing in the ED, like at many institutions I've worked at, then stress testing is the way to go if you're reliant on that approach to looking at ischemia-guided management. Of course, you also have to think about what other tests they've had recently. We didn't hear that in this history, but has the patient had a prior stress test that was inconclusive or mildly abnormal? We know that this patient exercised. Are they capable of exercise? If this person had a BMI of 40 and was not able to exercise, that would also point you towards CTA. But if they were exercising, you might want to get a good idea of a stress test on this patient. There are certain factors which would align you either way, and it really depends on that key clinical question you're asking. Do I want to identify coronary disease, particularly exclude it, or identify non-obstructive disease? This person has risk factors, and if you are thinking about a pathway of prevention, then understanding their burden of atherosclerotic plaque is also going to be important. If you really want to focus on a higher risk patient, then ischemia testing, I think, would be critical here. It's down to what questions you want answered.
And if I could just add something to that, Leslie, the point you made about incorporating prior testing is critical. So one of the nuances between the risk score-based clinical decision pathways, that means heart score, EDAC, what have you, versus, the troponin-based pathways, which effectively don't include clinical risk components, but really rely heavily on the biomarker. The risk score-based pathways tend to overestimate risk in populations because they incorporate things that we know cause problems, right? How many risk factors like hypertension, diabetes, hyperlipidemia do you have? But if you only look at those factors and you don't think about the prior testing that Leslie's alluding to, you can overestimate risk. If somebody comes in and they may be high risk by risk factors, but have had a recent coronary, CTA, they may be zero risk because we've just eliminated the idea that any plaque or stenosis exists. So I think that's an important nuance also to think about in intermediate risk patients. Incorporating the prior testing can help you get an intermediate risk patient out of the hospital because you already have the definitive information. The reason to code someone as intermediate risk is because we think more evaluation is needed. But if that additional evaluation was already done, then they're effectively low risk regardless of what their other factors show.
Particularly, I think, Phil, when you talk about somebody who has had a recent anatomic test like CT and there's no plaque, no stenosis, they've had that within the last 2 years. We know from a lot of observational data, the likelihood that they've all of a sudden developed a significant obstructive disease is very low. And so I think these are kind of reassurances, as Phil talks about, is to understand that patient can be safely discharged with that prior information.
Right. If ACS is what your primary focus is, keeping in mind that we all need to be clinicians, and if it's not the nail you were trying to hammer, perhaps it's another nail or even a whole nother floorboard that you're working on.
Let's move on to the second case.
So the next case is about nuances in the evaluation of chest pain in women. And by strict coincidence, this is also a 45-year-old woman. Not that we're picking on 45-year-old people in this whole presentation, but this is a 45-year-old healthy woman who presents to the emergency department for evaluation of chest pain and fatigue that's been present for 4 days but is now worsening. Similar to case one, this person also has life stressors. She's going through a divorce and has been experiencing more stress than usual. Initially, the symptoms were triggered by anxiousness and stress and resolved after a few seconds spontaneously. But last evening, she started developing persistent symptoms that became sharp in nature as well. No cough, no fever, no other worrisome clinical history findings other than a little bit of nausea, but no vomiting. And her vital signs, blood pressure slightly elevated at 145/80. In Detroit, I would count that as close to a controlled blood pressure because we have so much uncontrolled hypertension, but still elevated by standard criteria. And heart rate is normal at 85 beats per minute, as is respiratory rate at 18 breaths a minute. She's not febrile, and her pulse ox is normal on room air. She also has a body mass index of 27 kilograms per meter squared, which is slightly above normal, but not anywhere where we would consider her in the obese range. Her physical exam, she's well appearing, no diaphoresis, normal respirations, clear lungs, otherwise no cardiac murmurs or lower extremity edema, pulses are equal, and the rest of the exam is normal. And following the guidelines, the first thing we're doing in a suspected ACS case, or at least chest pain when we haven't quite differentiated it yet, is to get an electrocardiogram. It shows an incomplete right bundle branch block, but no evidence of ST segment changes. As we know, a right bundle branch block can be related to a number of different things, but it's not a particularly worrisome finding in the setting of ACS. Or suspected ACS. A chest x-ray, again, in accordance with the guidelines, was obtained. It's negative. Initial lab results showed mild hypokalemia, 3.2 millimoles per liter, and initial troponin, high sensitivity troponin I, was detectable, but below the 99th percentile. The assay we use in our facility, where this case was derived from, has a limit of detection, a reportable limit of detection of 3, and a 99th percentile of 18. The algorithm in place was a 2-hour, not 1-hour repeat algorithm, and repeat at 2 hours was 20 nanograms per liter, which is positive. Cardiology was consulted. Obviously, this is not somebody who's got a long history of prior workup. This is somebody who's relatively healthy before, has something that's inciting an acute precipitant potentially, but needs further evaluation. Cardiology is consulted, and as they often do, they came down and performed a bedside echo, which showed no wall motion abnormalities. But given her age, given the rise in her troponin, decision was made to take her to a coronary angiogram or angiography, which revealed a spontaneous coronary artery dissection. And that is a lot of what we wanted to highlight with this case, thinking about reasons why women may present differently and might have different etiologies.
Terrific, Phil. So can you just tell us when, in your opinion, is new onset angina no longer considered unstable angina?
Well, I think the most important thing is until you diagnose it, right? And so anybody who comes in with new onset or worsening angina with a history of chronic stable angina or anything that's out of the ordinary for them, it transitions, right? It could be unstable depending on what their clinical presentation is, but unstable angina, as we say, is really undifferentiated until we know what's going on. We talk a lot about how there's been a relative movement away from diagnosing unstable angina in the setting of high sensitivity troponins, right? If you have a negative high sensitivity troponin, it's probably not your heart that's causing the problem today, but that doesn't mean you don't have underlying stenosis that might be causing some functional, decreases in blood flow. So I think the key arbiter right here, whether it's acute or unstable, is really, how does this present? How does this patient present compared to prior symptoms? But has this been worked up before? And that's what I was really trying to highlight with this case. There's no reason in this 45-year-old woman with no other explanation for having a positive troponin to discount that lab value. I often tell my residents and other faculty members that you can't discount the lab results just because you don't like what it says, right? Just because you wanted to rule someone out and they rule in doesn't mean all of a sudden the information you gathered doesn't matter. And I think that's the mindset for me between acute and unstable angina.
So this patient had a non-STI segment elevation MI, acute coronary syndrome. Many hospitals across this country don't have cath labs. And so the question then comes up, well, okay, do you treat this conservatively? Do you do a stress test or a CTA?
Yeah, I think, I'm not sure who that's, directed. I'll just chime in and say, I want something. As an ER doc with this patient with the troponin of 20, you cardiologists tell me what we're getting, but we're getting something. And it's not discharge paperwork.
Let's ask Wael that, because I think Wael.
Yeah, Wael, I'm sorry, I should have directed it to Wael.
Oh, no worries, no worries. So this is actually, I'm not surprised he was managed. This patient, she was managed properly, given where she is. Phil, thank you. So the most important issues here were dealt with immediately. So you have a 45-year-old female, no risk factors. So by all risk scores, she's actually negative. She's basically low risk. Age and gender determine most of the risk, so she's there. And then the first troponin was negative. So now Phil is excited to send her home, and then she gets a positive troponin or a delta. So that a couple of things that go to mind here. First, this is an emotional stress situation. We all know about Takotsubo, so this was immediately ruled out with the echocardiogram that was performed. So that's something that I would think about. I would think, okay, am I missing a Takotsubo situation here? And we're seeing it more and more. I didn't see it during my fellowship once, and then now I see it maybe once a week. So that's one aspect. The other aspect is we have to think outside also. We have to think, does this patient have a pericardial effusion? Does she have pericarditis? Things like that, because she doesn't have the typical risk factors for CAD. So that also an echocardiogram is fantastic for that, a baseline echocardiogram. And again, she didn't have to have pericardial effusion. A proximal dissection in the ascending aorta would be seen by an echo. I'm not saying that's the right test, but at least if it's there, it will give you positive troponins. So all these things will give you positive troponins in someone with low probability for CAD or atherosclerosis. And finally, again, I'm not surprised the female, she ended up with the right diagnosis, which is, again, we see it now. We did not recognize it a long time ago, but now it's a common, not uncommon occurrence, which is a coronary dissection. So to your question, if she's had a CTA as an initial evaluation, that would have been detected readily by CTA. If she's had a stress test, an imaging stress test, and I'm sure Leslie, when she mentioned stress test earlier, she was talking all about imaging stress tests because the guidelines downgraded stress testing, EKG stress testing to 2A rather than class 1. So that's important. With an imaging stress test, most likely would have figured it out, but wouldn't have known what it was. Would have thought she had ischemia rather than we wouldn't have been able to determine the anatomy. So again, I don't think this is a person who should be sent home, one. And if anything, if you don't have the cath lab facilities, this patient should have been transferred to a center where they can deal with it.
So you would say transfer to a center rather than doing a CTA at your own center?
No, if you have CTA, that's fine. I'm happy with the
Okay.
CTA.
Okay.
If again, as Leslie said earlier, you have to be comfortable. This is not an easy diagnosis on CTA. This could be missed.
Yeah, it could be missed. And it looks like non-calcified plaque in times. There's more and more evidence with CT. I think, in order for us to be very fair to the audience, right, we need more evidence on workup of SCAD in general. And we need more evidence with CT, but Wael's answer was absolutely amazing.
Yeah, and of course, if you put somebody with SCAD and exercise them,
Yeah.
that's kind of scary. We don't want
It's
it to.
scary.
I
I
know
don't
that
want to dissect it anymore, right?
I know
So-
that didn't happen here, but that just a word of caution. So Deb, as the interventionalist here with us, tell me your thoughts. Would you have liked this patient to have gone to the cath lab earlier? Because in this particular case, it was the next day, if I remember correctly. So what would be your approach? Anything different?
And so I do think she was managed appropriately, Dr. Levy and Dr. Vargas. So our guidelines, that diagnostic guidelines, doesn't go into management and the role of invasive angiography. But another guideline came out at the same time, very very close to our guideline, the 2021 JACC revascularization guideline actually does address this. And if she had a troponin of 20, 5 times elevation, she needed to go to the cath lab. I think very few hospitals would do, honestly, CTA or any kind of stress testing. The thing you worry about common, even in a 45-year-old today, is coronary artery disease and plaque rupture. And a SCAD is a possibility, as there are other possibilities. And the 2021 HACC guidelines asks us to use another risk called GRACE, which is for non-STACS. You can use TIMI-2, which can be used with chest pain. And they divide patients into low risk based on GRACE 2 risk score. So less than 108 is low risk, 108 to 140 is intermediate, more than 140 is high risk. The high risk individuals need to go in a few hours, but a low risk individual, I think it's reasonable to have her go to the cath lab in 24 to 48 hours. So I think timing was not an issue. And furthermore, SCAD, even if you find it, unless it's flow limiting, it's managed conservatively. You leave it alone, it heals. And sometimes the artery looks like new once the dissection is healed.
So let me just follow up on a comment that Wael made about the fact that we're seeing more and more Takotsubo probably the same thing, we're seeing more and more ANOCA diagnosed. Any thoughts? Are we just doing more procedures, getting better at what we do? I'll throw that to anyone who wants to answer it. Leslie, Deb,
I think I'll start. I think like similar to SCAD and Takotsubo, there is more awareness. There's certainly maybe, if certainly COVID pandemic, the stress level has increased significantly. We certainly have seen an uptick in Takotsubo and stress cardiomyopathy during this last 2 years. With INOCA, I think there is awareness. There are specific tests now available, which weren't available years ago with coronary, flow reserve. The IMR ratio, certainly non-invasive with PET and cardiac magnetic resonance. So there is more awareness, and there is a significant group of patients which we probably missed in the past. We told them you don't have coronary artery disease, and sometimes we told them we don't know what the pain is from or what the enzyme is from, but you are fine. But I think we're realizing those individuals need to be treated appropriately with guideline-directed medical therapy and with preventive medication.
and hopefully these guidelines will get everybody thinking in that category, in that sense.
I fully agree. It's an issue of awareness too. So again, these guidelines had a full section on women. And I think in the past, maybe in the 70s and 80s and even before, a lot of women with chest pain would have been ignored completely or have been sent home with Takotsubo. So we have the tools to now, not only women are more aware that they're atypical in their chest pain. Sorry for using the word atypical, Martha. I know you've wanted to throw this
You're in
out.
trouble now.
I'm sorry.
But they don't have the typical chest pain, which sounds less cardiac. But also we have the readily available echocardiography in the ER right now. In the past, they would wait, let's say, from Friday to Monday. And those of us who deal with Takotsubo, they know it will be gone by Monday. So by the time we do the echo on Monday, it will be gone. So a lot of these instances where we're immediately diagnosing it in the ER on admission. At least our center, and I'm sure many centers you guys practice at, most of our patients get an echo before they hit the floor or immediately when they hit the floor. So that's again an awareness plus awareness and ability to deliver the test to the site to where the patient is.
Deb, can I ask you one question? So if there was no SCAD, would you do any other workup? So if there's no obstructive disease, no SCAD, what do you do in your cath lab next?
So this would be INOCA or myocardial infarction. This is not INOCA. So this is myocardial infarction with normal coronary arteries, and there are multiple causes. It's a heterogeneous condition. Could be coronary vasospasm, severe coronary vasospasm. It could be myocarditis that can cause elevation in biomarkers in her. Actually, INOCA, particularly if the ST elevation, which this person did not have, there's often plaque rupture, but it's a non-obstructive plaque. There's plaque rupture, and then a thrombus that forms that autolysis. So by the time you cath, you may not see the obstruction, and there is recommendation you do OCT and IVUS in the cath lab. Certainly, if you're thinking of microvascular obstruction, you can do index of microcirculatory resistance or IMR, you can do coronary flow reserve. But some of this myocardial dysfunction are better tested non-invasively with either, and Leslie can talk more about it, with either cardiac magnetic resonance imaging or with PET scan to look at the microvascular reserve. In the cath lab, I do OCT, IVUS to make sure there's no plaque rupture. And if there is a concern, certainly there are, in the cath lab, we can do coronary flow reserve and IMR or index of microvasculatory resistance.
Yeah, I think at MR there's a lot of evidence on the use of MR for particularly diagnosis of myocarditis and using CMR. I think it's something else to add to that equation.
So
Right,
Martha,
so
you want to
Yes.
introduce the third case?
Yeah, that's where I was going. So
All
we're
right.
thinking along the same line. So we now have Dr. Tiffany Dong, who will be presenting her case to us.
You just start then. Okay.
We see your slides, so you're good.
You see my slides? Okay, good. All right. So I have this case triaging down the new chest pain guidelines. So we're in the emergency department. We're seeing a 76-year-old female coming in with chest pain that she describes burning, radiating to her left shoulder. This has kind of progressed over the past 2 weeks and is associated with belching, which led to her delayed presentation. It's worse with exertion and alleviated by rest. In terms of past medical and past social history, so she has prediabetes, she has sleep apnea using a CPAP machine, asthma and osteoporosis. She's on no cardiac medications. And then she does have prior tobacco use, but she quit many years prior to us seeing her, and no other substance use. In terms of her vitals and physical exam, vitals were notable for a blood pressure of 168/71. And otherwise, she was stable and her exam was fairly unremarkable. So her first EKG is taken in the emergency room. As you can see, it's normal sinus rhythm, doesn't really show any specific ST changes. And then we do a repeat EKG with very similar findings. And then in terms of her laboratory studies, so her CBC and BNP were unremarkable. She was COVID negative. However, her high sensitivity troponin repeated were 56, 52, and 50, with our assay being less than 12 as significant, or sorry, as not significant. And then her troponin T was also elevated at 0.023 and then repeat 0.039. We calculated her GRACE and TIMI score to be 106 and 3 respectively, so there is some discrepancy on how you classify her. And this was her chest x-ray, which was also fairly unremarkable. So we classified her, given her age, into this intermediate risk category and thus proceeded with stress testing. So she got a SPECT CT done at our institution that was concerning for a moderate amount of ischemia in the RCA region, as well as a mild amount of ischemia in the circ area. And so we proceeded to left heart cath based on these findings. And this is her coronary angiogram. So as you can see for her circ, she did have a severe lesion proximally. And then this is the shot of her RCA. And they confirmed with IVUS, but it was determined that she had a mid-severe RCA lesion as well. So she did undergo stenting to both the circ and RCA. And then she was discharged on a high-dose statin, metoprolol tartrate, 12.5 milligrams twice a day, aspirin, 81 milligrams, and Plavix or clopidogrel, 75 milligrams daily, and also underwent cardiac rehab. I'll stop sharing at this point.
Great. I think it's important for the individuals viewing this webinar that they go back and read these case reports and JACC case reports, because it really does go into in-depth discussion about how the decisions were made. And this webinar is really just to go further on beyond those questions. And so that's why some of these the specific questions that are being asked today, but it's worth going back. The authors here did a great job in these case reports. So I do have a question. Wael, maybe you can answer this. And we talked about risk scores and which one you use. What about the female patient? Any one risk score better than the other? How do we make this decision?
Again, I go back to my prior point I made earlier. The risk scores, even the overall estimation of risk score that we dealt with from the 1970s and 80s with the Diamond, Foster, and all these risk scores, they give primacy to age and gender. And it's very hard to actually be high risk in the high risk or intermediate high risk category, especially for females, unless they're much older. So just keep that in mind when you're looking at these risk scores. Now, as far as looking at the general risk scores we use in the emergency department, let's say the heart score, there are many studies. There's a big study from the Netherlands looking at that, and finding that the risk in males, even for the same number, for the same figure you get, is twice what you get in females. So it turns out that these scores are not gender neutral. although we treat them that way in the after we get the number at the end in the ER. So whatever the number you get, you're gonna think, okay, these people have the same outcome, but that's not true. So I am not personally, you know, as again, Phil said this earlier, it's very nicely, is whatever you're comfortable with in your institution is fine. And this patient, is if you notice, based on her enzymes, she would have actually been discharged home. It's based on her risk score that she was kept in. So the enzymes are, the assays are extremely important for short-term risk. But again, we're not asking you to completely discount your judgment and just say, you know, I have a number here and I'm going to move on with it. The risk score here has helped us at least keep this patient in, stress her, and identify disease. So this is how I look at them. I don't favor one over the other, and I'm not sure if any of you guys is more familiar with a risk score that works better for females.
I think, as Dr. Dong said, there was some discrepancy in the two risk scores. So you're going to have people arguing, well, that doesn't help me. Just send the patient to the cath lab, period.
And in medicine, uncertainty creates more testing, right?
There you go.
All right, and Phil, I wanted to ask you, you know, our guidelines obviously prefer troponins, recommend troponins, and preferentially prefer high sensitivity troponin. And so can you tell us a little bit about the advantages of high sensitivity troponin and try to answer also the question if the biomarker in and of itself is too sensitive?
Again, it goes back to a little bit of what I said, is you can't fault the test if you got the result that you didn't want, right? And so that's a really important thing to keep in mind. You know, when you come to the ER and we're screening you for something, the reason to get the troponin is not to validate the low risk concern, although that may be, you know, one reason to get it. But depending on the community you're in, you're not likely to rule a lot of people out just on that single biomarker. The European data, where they talk about 60% or so of people being ruled out as low risk based on troponin-only protocols, doesn't happen in Detroit, where it's a predominantly, you know, African-American population with a high degree of uncontrolled hypertension and very, you know, high prevalence of left ventricular hypertrophy. There's just troponin everywhere in that person, right? It's not positive troponin. It's not 99th percentile or greater troponin, but it's there. And the reality is that the prognostic information of troponin is as valuable as the diagnostic information. So we use this marker for multiple purposes. And I think that's the real value that you get from the high sensitivity troponin. It's a great marker to rule stuff out. When it's negative, it's truly negative. When it's positive, as we saw with case number 2, it's positive. When it's positive, as with case number 3, you have to have some clinical judgment to throw on top of this, because this person's delta wouldn't have moved enough to raise flags based on most institutional protocols. There was a dynamic change, but not a marked dynamic change. So, you know, that's where a little additional information really, you know, really helps out there. But I think where, you know, where you can take it from a prognostic perspective is back to, you know, the first case question was, how quickly does someone need follow-up, right? If someone rules out, but they have some detectable troponin, the delta is not really rising, they're in that intermediate troponin range, their risk in 30 days may be minimal, but their risk at 1 year may be 5% or greater. And we have to get out of the mindset that troponin only exists dichotomously to say yes or no, right? I have coronary disease or I don't, and instead look at it and say, you know, a 50-year-old black male comes to the ER with hypertension and diabetes and their troponin is 8 and the next one's 9, that person's not the same as somebody else who has undetectable troponin at all. So I'd say, you know, from a population health prevention perspective, I think troponin is a great marker because it gives you information that helps you not today or tomorrow, but maybe, you know, weeks or even close to a year down the road. That said, it's very frustrating, I know, from the cardiology side to get the calls constantly about marginally elevated troponins that, you know, that we don't know what to do with or don't really want to deal with from the emergency department. And that's where, you know, again, going back to the prior testing is so important, because to put all of your eggs in the one marker basket is the wrong way to do it. Let's practice within nuances and understand, you know, how we interpret the troponin values within clinical context.
Right. And also in our guidelines, we didn't recommend sex-specific cutoffs. And can you tell our audience why we decided not to?
Yeah, it's kind of similar to why we didn't say this is the, you know, the cutoff for a negative, or this is the cutoff for a 99th percentile, because this is a work in evolution. If we were to go back just, you know, 4 years ago when we started all this process, troponin was a relative value, right? It was a percentage increase, and then it became an absolute increase or change over time. And I think the field is just continually evolving. And the markers, right? We do know that sex-specific cut points will increase the proportion of women who are diagnosed with MI. It probably is not going to decrease the proportion of men diagnosed with MI, or at least values above the 99th percentile. But does that help us get at who has more disease underneath in the coronary arteries, or does it help us determine prognosis in that population? And I think, we wanted these guidelines to be enduring. We didn't want to have time-stamped numerical data that says this is what you can hang your hat on. As we've seen in the European Society of Cardiology guidelines that came out in 2016, revised in 2020, those numbers are going to change over time. So we created something that would survive the test of time.
Terrific.
Leslie, so we saw this patient wound up having coronary disease, but could have been sent home, right? What if they had an indeterminate stress test as an outpatient somewhere along the line? How would that have changed any direction and how this, this played out? Thoughts?
Yeah, I think from the patient's perspective, right, indeterminate or testing is frustrating, right? And the patient presents now, they're obviously concerned about that. They go to the ED, and the answer needs to happen, right? And don't perpetuate and don't repeat another test which has a high likelihood of being inconclusive again, right? And the old adage of doing something a second time. I think you know the rest of that story. But, so here's an opportunity. Inconclusive prior stress test can happen for a lot of reasons: comorbidities, orthopedic limitations, submaximal exercise, poor exercise capacity, etc. Don't repeat the same inconclusive test. And this is a time to shift to anatomic testing. In this case, give this woman an answer to whether or not she has anatomic coronary disease, and a non-invasive, less expensive pathway than in other options. And I think this is just something that is just such a no-brainer. I think that we added to the guidelines is, look at what you have if you have the information in front of you about prior testing, incorporate that into your decision-making and test options.
Because some would say, well, she didn't have a high-risk stress test, so just move on and send her out. But your point is well taken.
Yeah, I think there's a lot of undervaluing. And it is, I think, as Phil talked about, this stress test normal, abnormal. You've got to know if it was normal or mildly abnormal, if it was inconclusive. Did they have good exercise tolerance? Was the image quality sufficient? In this case, in not only in Detroit, but in New York, obesity, a lot of reasons why you can have poor image quality. And these are factors which are going to determine your next test options, critically important to determine your next test options. Of course, poor image quality doesn't happen at any of your institutions.
So the bottom line, you really need to know the details.
Need to know the details.
One more thing just a bit
really
about stress testing, because I think Leslie and I have been talking about that everywhere we can talk about it, is a lot of these tests have right now in a modern lab a CT with them. So a SPECT we did here at our institution, at least, in many places, they have a CT attenuation correction as part of the test. That CT is a freebie. And you should look at atherosclerosis there. You should look at, even if the test is normal, so-called normal, if the patient has a lot of burden of disease, calcifications, that you can see very, very easily even on a poor CT. That should not be ignored, and that should be an opportunity for these patients to have risk factor modifications and GDMT. So that's extremely important.
Outstanding point. Look at what you have right in front of you, right? And so if you're doing stress nuclear, that CT is right there. See if they have any calcification. Outstanding point.
I also want to just go back to the point you made, Leslie, like with the way people interpret stress testing sometimes is simply normal or abnormal. And it is my pet peeve with my fellows. I try to teach them that the way they're going to present the test to me is with all the stress information, the heart rate response, the blood pressure response, how long they exercised, or their METs. I want to know all that information to even say that, yes, that was a normal stress test versus that was a normal image, but you didn't really stress this person enough. And I think, for a variety of reasons that might happen, but it is my pet peeve when we use our stress testing as that it's just the imaging, that's simply what they're going to report back to us.
And Martha,
More often than not, my question is, why didn't they walk you? Too many
Yeah.
pharmacological stress tests. Person looks, well, you can walk pretty well. Why
Yeah.
didn't they walk you? Because that gives you a lot of information, you know.
Exactly.
I think that's fundamental to particularly cardiology fellow training. Exercise physiology is fundamental to understanding demand ischemia. Fundamental, right? And
Absolutely.
so we really have to make sure that people understand the principles of exercise testing. And we are relying too much on pharmacologic stress because it's easier, right?
Mhm.
You don't have to worry about it's a focus on throughput, et cetera. Let's get back to giving the patient the right answer. Let's give them particularly advice around their activities of daily living. It's so fundamental to caring for them.
Well said.
All right, I think
And feel free to put something in the conclusion that tells us ER docs what we should do with it when they come back. Because honestly, it's not that, we're not cognitively capable of doing this, but there's so much going on. And most of us are just going to drop down to the final impression and want to know what to do with the next steps. And so oftentimes, because we can't interpret it because we don't have the background, the reflexes to page cardiology, just to have you guys look at the stress test and say, well, this patient can go home. And so, that's part of this multidisciplinary nature and this, this process that I think the guidelines really brought together. The fact that it was cardiologists, emergency medicine physicians, hospitalists coming together to really put together a pathway that we all can manage this very common condition.
I think we'll move on to the fourth case. I think Dr. Dong, you're presenting again.
Yes, that's correct. Just give me a minute to pull this up. There we go. Okay. Okay, so the next case is dissecting into the 2021 chest pain guidelines. So again, we're in the emergency room department with a chief complaint of chest pain. We have a 70-year-old male presenting with sudden onset mid-sternal chest pain that started at rest and has been ongoing for the past 6 hours. It doesn't radiate anywhere, but it is associated with shortness of breath and non-bilious emesis. He does have quite the extensive cardiac history, including ischemic heart disease with a reduced ejection fraction of 37%. He underwent a CABG a month prior to presentation with Lima to LAD, vein graft to diag, vein graft to circ, and a vein graft to his RCA. In addition, he had moderate mitral regurgitation and tricuspid regurgitation, which we both received rings and a stitch for, respectively. He has hypertension, paroxysmal atrial fibrillation, hyperlipidemia, diabetes, peripheral arterial disease, and prostate issues. And then I forgot to mention he did have a PCI to his RCA prior to his CABG. In terms of medications, so he's on aspirin, 81 daily, carvedilol 12 milligrams twice a day, amiodarone 200 daily, atorvastatin 80 daily, hydralazine 100 3 times a day, isosorbide dinitrate 10 milligrams 3 times a day, and insulin. His social history was unremarkable, and his family history was notable for both parents with a history of coronary disease. In the emergency room, his vitals were fairly unremarkable, and his exam was also unremarkable, including his vascular exam. In terms of his EKG, so this shows normal sinus rhythm with left axis deviation, and then he did have these anterior and inferior Q waves that were stable from prior. We repeated an EKG. It's slightly slower rate at this point, but similar findings. And then lab-wise, so this was before the era of high sensitivity troponins, but CBC and BNP notable for creatinine of 1.2, which was his baseline. In addition, you can see his sternotomy or sternal wires on his chest X-ray, and his troponin T was 0.08 and 0.07, so fairly flat between the two measurements. So in the emergency room, they obtained a CT PE protocol, And this showed a type A dissection extending from the sinotubular junction along the right posterior arch of the ascending aorta. And then the false lumen did extend to the abdominal aorta, but we don't have any views of we don't have a dedicated CT abdomen pelvis. So a bedside echo confirmed these findings. You can see 2D on the left with that false lumen and the true lumen and the dissection flap. In addition, color flow kind of identified where the true lumen was. So he was transferred to our cardiac ICU, which is kind of standard of practice here, with emergent CTS consultation. Started on impulse control with nitroprusside starting at 20 and metoprolol 5 milligrams IV pushes as needed. In addition, we gave him morphine 1 milligram every 15 minutes as needed for breakthrough pain. Unfortunately, he developed an AKI. His creatinine peaked at 4.32. And so CT of the abdomen and pelvis with contrast was deferred. However, he did get a renal vascular ultrasound that showed high resistive flow in both renal arteries and low flow within the renal parenchyma. So it's concerning that maybe this dissection was playing a role into his AKI. He was deemed too high risk for open repair, and he underwent a TVAR ultimately with a thoracic stent graft from celiac artery to the renal artery and CTAG thoracic stent graft from the left subclavian to the celiac artery. The mid to distal ascending dissection was not addressed due to concern of bypass grafts, which were patent back in the OR. Thankfully, his AKI resolved and he was discharged to rehab, and his medications, I didn't include his whole list, but it did. We did bump up his carvedilol to 25 milligrams twice a day, added amlodipine 10 milligrams daily, and furosemide 20 milligrams daily.
Terrific. So I'm going to ask Wael a question, because it sounds like in this particular case they were doing a CT for to look for a PE, but found the aortic dissection. And I think we can't lose sight of other things, other causes of chest pain. You know, this is a great case to demonstrate that it's not all coronary artery disease, even with somebody with a history of coronary artery disease. But well, what are the things that we look for on physical exam to maybe hint at other causes?
So a couple of things that beyond ischemia. So beyond ischemia, you would look for, let's say, start with the pericardium first. So you think you hope you can hear a pericardial rub. I'm sure our patients are similar to Phil's patients. Our average BMI, actually a patient presenting to the stress lab is 36 and above. So we're friction low, but you have to know how to listen to it. On the physical exam, in a patient with dissection, you'd expect some differences in pulses between left and right, or drop in pulses in the lower extremities if you're talking about a descending aortic dissection, difference in pulses or absence of pulse or an ischemic limb. Unfortunately, for a lot of CAD stuff, the physical exam is quite limited. If you get this patient, don't waste your time spending an hour and a half doing a full physical exam. A CAD physical exam is a quick physical exam, trying to make sure that the patient doesn't have what I just mentioned, a rub, doesn't have a murmur of aortic stenosis, of ischemic mitral regurgitation in the setting of an acute MI. But these are the things I look for. I usually do quickly on these patients. It's just do a quick physical exam, feel the pulses of the lower extremities. Don't be afraid of that, and go from there. One of the tools we have right now, and I'm glad I used to be resistant to it as an echocardiographer, is miniaturization of echo and deploying it everywhere. I think people are getting more and more comfortable with it, and I think we should capitalize on that. This patient would have been diagnosed even in the ER without a CT if an echo was done as a first step. But it happened this way, and that's fine.
So I have a few questions on CTs, and I'm going to start with Leslie. This patient had prior bypass. How good is a CTA for bypass surgery patients? When do you use it? When don't you use it?
You know, generally bypass grafts are larger and they're easier to visualize, both graft patency stents. And so that's a general statement. And we also know from the natural history of progression, there's less calcification in a bypass graft, right? And so that is also makes it more beneficial to use CT. So CT does a pretty good job of looking at graft patency, does a pretty good job of looking at the severity of stenosis in there. And there's a fair amount of evidence that it is very highly accurate, well in excess of 90%, to look at graft patency. So it's a pretty good choice here.
Perfect. And Deb, could I ask you a question? So why are there's still continued delays though in diagnosing aortic dissections in the community? And what are the reasons for that?
Right. One of the biggest challenges is aortic dissection tends to have similar risk factors and clinical presentation as acute coronary syndrome, which is much more common. So somebody comes in with chest pain, back pain, and hypertension, diabetes, and all of these risk factors. The first thing that comes to somebody's mind is ACS. They get workup, and it's not uncommon for an aortic dissection patient to even end up in the cath lab. They can have elevated troponin just from the aortic dissection. Sometimes the aortic dissection can actually involve the right coronary artery, can even cause STEMI in about 10%. I think just like every other condition or disease, history and physical is important. And, spending 5 minutes, if the pain is really tearing, ripping in the back, if they have pulse deficit, if they have a simple chest X-ray and a widened mediastinum, those three, there's a 90% chance. But sometimes you're so focused on aortic acute coronary syndrome that you don't look at some of the signals that may be there on physical exam or on history. There is actually a lot of good data I read, which is developed by Kim Eagle from University of Michigan, and they have data on over 2,000, I think, aortic dissection patients. There are some factors like female gender or sex. If they don't have typical presentation, I'm using typical because that's what they used in their papers. If it's not abrupt onset pain, if it is more dull, if they don't have pulse deficit, if they're present in an outlying hospital, certain diversity issues, so being non-white, there are some delays. The Minneapolis group also looked at it, and again, unusual or atypical presentation, people may get diagnosed with a PE or the thought maybe PE, and sometimes they'll get a CTA, just like this person. And sometimes they get CTAs for coronary artery disease, and you find the aortic dissection. Again, for type aortic dissection, I want to reinforce what Wael said, a transthoracic echo can sometimes diagnose, and our guidelines give a class 1 recommendation for somebody to get a transthoracic echo for anybody with chest pain. But I think the biggest issue is that it mimics acute coronary syndrome too much, and that's what everybody's thinking about. That's common.
So Phil, they were thinking PE, they did a CT PE, they found an aortic dissection. What about the triple rule out? What's your feeling about the use of a triple rule out in the ER?
Well, it goes back to the adage, right? It's better to be lucky than good. And so, it's good to pick up on whatever you can, however you can pick up on it. And as we were thinking through this case or talking it through, the triple rule out is something that came to mind for me. It's not done as routinely as perhaps some of us would like to see in emergency departments, because it does provide tremendous value, but we also don't want to use it as a standard rule out protocol for everybody. And that's the danger with the triple rule out, is that it's very easy to order the scan, get a relatively high dye load in somebody for a person that you probably could have predicted based on all the things that we talked about previously was low risk and didn't need any imaging. And so that's some of the pushback that has come specifically with the triple rule out in CTA as a diagnostic measure in already low risk people. You're not going to take someone who's low risk and make them really low risk. They're already low risk. But the triple rule out, I think, when you're uncertain and something is going on, is a very valuable approach if you have the right radiology group or cardiology group who's ever reading them. But that also presents some of the challenge, who reads what aspect, because in some places, right, cardiology is specific to the coronaries, and then radiology is the rest of it. And so those agreements are things that have to be worked out ahead of time as well. But suffice to say, triple rule out would have been my preferred test in a person like this if I had any inkling beyond, PE, but the history is a little difficult there. Nothing really jumps out and says it's one of these three diagnoses more than any of the others.
So that's why a triple rule out would have been probably, as you said, because nothing led you in the right path here.
Yep. I mean, the only thing that led you maybe away from ACS was the fact that the troponin wasn't elevated. The delta wasn't something that would trigger, a concern for ACS. But, to Wael's point, if you're going to look at the aorta for, dissection, you're going to look at the pulmonary arteries for PE, and throw the coronaries on there too, and take a look while you're at it. And, maybe it's the case, and Leslie, I don't know how you feel about this, but, doing a quick look at calcium buildup before you inject the coronaries just to get a sense if there's anything going on. I haven't heard too many protocols going in that direction, although, we talked a lot in the guidelines about incidental finding of coronary calcification on thoracic CTs.
Yeah,
And
I think
to the credit of the physicians caring for the patient did well.
Yes. All these
Complex
patients
case.
did well. It's amazing how that happens when you write the cases.
the big challenge with
Always
the triple
happens here.
rule out is what Phil talks about is finding the right patient. It's associated with more radiation, so you really want to make sure it's the right patient. And I think this was a great case for that. It really illustrated that, but you don't want to perform it in lower risk patients where you're giving them a lot more radiation than needs be. Well said.
Is why we didn't
Jesus,
endorse it in our guidelines. So again, I'd like to first of all thank our presenters of the cases who wrote them up so beautifully, and you can see them, as Dr. Fischman said, you can see them in JACC case reports and really read them because they are very well done, and we are very pleased to have an issue that coincided with the release of our guidelines and to really demonstrate the utility of our guidelines. I'd like to also thank our wonderful panel for joining us today and discussing, more than just the cases, but really the guidelines and how to use them in your clinical practice. We can tell one thing from this group that I still need to wash their mouths out with soap because there's a lot, too much use of the word atypical on this presentation. But I still have time to get that out of your language. I'd like to thank Dr. Fischman for representing JACC case reports with us here today and giving us this platform. So thank you, everyone, and thank you to our audience for joining us here today.
Thank you, Martha
Martha.
and
Thank you,
David.
everyone.
Thank you,
Awesome,
everyone.
guys.
Thanks,
Thanks,
Rakhee.
Good job. Have a great night.
Right?
Thank you, everyone.
Everyone.